10 a.m. or on YouTube, channel 𝗛𝗲𝗪 8:10 a.m. Radio Bandido.
The views and comments of the hosts and guests are not necessarily those of the station.
Hi, I'm Nicole, Jacinto. Join us on Healthline with 𝗏𝗏𝗵𝗹 as we discuss the latest health and medical topics with doctors from 𝗏𝗏𝗵𝗹. For a healthier and uplifting lifestyle, tune into Healthline with 𝗏𝗏𝗵𝗹 on 𝗛𝗲𝗪 8:10 a.m. Radio Bandido TV. You've got questions, we've got answers.
Watch and listen to Healthline with 𝗏𝗏𝗵𝗹, Mondays, 5 p.m. to 6 p.m. Airing on Sky Cable Channel 224 and on all DTT boxes. Simulcasting online on Facebook and YouTube. Listen and watch on your mobile devices. Just search 𝗛𝗲𝗪 Radio Bandido.
You're about to experience Healthline, a show where doctors from 𝗏𝗏𝗵𝗹 interact with you for a healthy, uplifting lifestyle. Moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome to Healthline.
Hi, everybody, and welcome to Healthline with 𝗏𝗏𝗵𝗹. I'm your host, Nicole Jacinto. Okay, today with us on the show, we have Dr. Maria Princess 𝗛𝗲𝗁𝗏𝗵𝗃. Good afternoon, Dr. 𝗁𝗏𝗃. How are you today?
Hi, Nicole. Good afternoon. I'm good. Thank you for asking. How are you, Nicole?
I'm okay. Sometimes I take long to answer because when people ask me how I am, I'm thinking about all the internal stuff, and people just really want to hear that I'm fine. But anyway, doctor, today we're going to talk about, and folks, people in the audience, we're going to talk about thyroid cancer. And of course, Dr. and it's located, of course, in Makati City. Now, doctor, before we begin and we delve into the discussion of thyroid cancer, can you just give us a brief overview of what the thyroid gland is, like where is it located in the body and what is its function?
Okay, thank you for that question because I have props, Nicole. Okay, here. I got this from my clinic. I'm already home now, because it's in the afternoon already. I have clinic in the morning. So this is what a thyroid gland would look like. Because some people are really confused. Where is it? They don't know where it is. Actually, so the thyroid gland is located in your neck, no? It's a base of the neck. It's here. So if you would look inside, if somebody would open this up, it will look like this. This is your windpipe or your trachea, and it's in front of your trachea. It's actually, look at it. It actually looks like a butterfly, diba?
Yes.
So this is a thyroid gland. It looks like a butterfly. The size of this is like about around 2 inches in height, about 5 centimeters. And this one will be like 2 centimeters. Ayan, here. This is the right. This is on my right. So this is the right lobe. This is the left lobe. And we have the isthmus. The isthmus connects your right and left lobe. And this is how the gland would look like. And there. So this is the thyroid gland.
Thank you,
the thyroid gland is responsible for making thyroid hormones.
Okay. And those hormones, doctor, it's important for the whole body, no, as well. Just a brief overview of what they do for us, what those hormones basically release, and how it helps the rest of the body, how it works with the rest of the body.
Okay, the thyroid hormones will be responsible for the metabolism that regulates the metabolism in our body. So what is metabolism? It is actually responsible in controlling your body temperature, your blood pressure, even your heart rate. So it's a big, it has a very big role in the upkeep of our body.
Okay. Thank you, doctor. So it's responsible for a lot of things, metabolism, even your weight. I'm just repeating what you said, and please jump in anytime to correct me if I got it wrong or I'm missing something, and even up to your heartbeat. So I guess you could, as you said, your body temperature. So you may be getting like fever and things, and not really knowing or feeling cold for no reason. So it really does play a big role in the body, and it affects a lot of I guess other symptoms that we can feel, that we can really feel as we go about on our daily journey. Okay, doctor, so let's jump into it. What happens when when one gets thyroid or develops thyroid cancer. So basically, what is thyroid cancer, and how does it develop?
Okay, thyroid cancer actually is when the cells in the thyroid gland develop changes in the DNA. So molecular level siya, di ba, DNA? So a cell's DNA actually contains the instructions that will tell the cell of the thyroid what to do. So if there are changes, we call it mutations, no? It tells the cells to grow and multiply rapidly when it shouldn't be multiplying and growing rapidly. The mutation does that. So the cell goes on living when the healthy cells would naturally die. So the accumulating cells form a mass and is called a tumor. And some of this tumor could actually be cancer.
Okay. All right. So just to get that, my understanding of what you said is but it's in the thyroid are supposed to die off because they will produce new ones, no?
Yes.
Healthy ones. The healthy cells that are supposed to die off don't end up dying off. So basically, they're not healthy cells anymore.
Yes, they're not healthy cells anymore. Correct.
Okay. And then there's this trigger, as I guess with I don't know what to call it, with all cancers, where it's supposed to say, or tumors, not cancers, but where it's supposed to say, okay, you die already, you unhealthy cell, and shed, or whatever process goes on in the body. But because of a mutation, these cells do not
die. They actually grow. And they multiply.
They multiply, and they're not healthy cells that the thyroid or your body.
Yes.
And then it can become a mass or a tumor. What causes this? Is it genetic? Is it lifestyle, or is it a mixture of both? If I may just ask very quickly.
Actually, the reason why one would have cancer of the thyroid gland, actually doctors and even experts are not really sure why the cells in the thyroid gland becomes malignant, and why there are these things that attacks the thyroid, no? But there are factors that actually could pose as risk factors that eventually is the reason, that could be reasons why one would have thyroid cancer. One of these factors actually would be present to you and me. It's being female, no? The female sex, no, can actually be a risk for somebody to develop thyroid cancer. So it occurs more in women than in men. And experts may think that it is actually related to another hormone which is present among us women only. It's the estrogen. The other possible reason could be exposure to high levels of radiation. For example, a person would have been treated for a different disease, like there will be radiation therapy treatment to the head or even to the neck. So the neck is where the thyroid is. So if there's radiation therapy here on the head, it exposes the thyroid gland. The thyroid gland is very sensitive. So it makes the thyroid produce more cells, rapidly produce cells, or have cancer cells. No? The other one, which we could not change, it is inherited genetic syndromes, or some types of thyroid cancer can sometimes run in the family. So it's called medullary. I'll talk about that later. And papillary thyroid cancer. These are, namamana, or these are gene-related type of cancers.
Okay. Thank you, doctor. Okay. So, doctor, what are the most common types of thyroid cancers? I understand there are different types, or are there different types?
Nicole, there are really different types of thyroid cancers. No?
Okay.
So the thyroid cancer could be classified into well-differentiated, and there are two. It's called a papillary thyroid cancer. The other one is follicular thyroid cancer. So let us differentiate the two types. No, these are what we call when we talk to our patients, and they're so scared, they're so afraid. I have cancer, doctora. These are what we call the more friendly of the type of cancer. If ever you develop a thyroid cancer, no? So papillary thyroid cancer happens about 80%. So 80% of all cancers will be papillary thyroid cancer. It is the most common type, and it can happen actually in any age, but it'll be more often seen among patients who are between 30 to 50 years of age. And this tumor, or this cancer type, actually grows very slowly. Although,
between age again?
Age 30 to 50. So between age 30 to 50, we already see
30 to
patients
50,
coming to us, no, and they say they have a lump, and then when we check, most probably it'll be a papillary type of thyroid cancer. So it often this kind of papillary cancer often spreads to the lymph node. So the lymph node of the thyroid gland will be here. No, there are areas here that has lymph nodes. So most of the time, it's where it spreads. No, and but we should not be too scared of a papillary cancer because this disease responds very well to treatment. No, it is highly curable and rarely fatal or rarely deadly. The other type of the well-differentiated cancer is the follicular one. The follicular cancer will account for up to 15% of the thyroid cancer. This is a little bit more rare than your papillary, which is 80%, no? And it usually affects the older people, not naman older, mga age more than 50, more than 50 years old. So the follicular thyroid cancer cells don't often spread here, no, on the lymph nodes of the neck, pero they tend to spread to other organs, which is farther than the neck. It could be your bones, it could be your lungs. So it looks a little bit more challenging to treat than your papillary type cancer. So that's the two well differentiated, the papillary and the follicular. And then we go to the rarer ones. It's called a medullary thyroid cancer. This accounts for only 2%. No, 2%. This is this type of cancer begins in the thyroid cells. There are cells called the C cells, and these cells produce the hormone calcitonin. Actually, you can check the level of your calcitonin in your blood, and if ever you have elevated level of calcitonin, so it could indicate a medullary thyroid cancer if you have thyroid nodules, or we'll call it tumor. So if you check your calcitonin, you could detect medullary thyroid cancer at an early stage. No. Some medullary thyroid cancer is called caused by a gene. It's called the RET or RET gene that's passed from parents to children. So ito yung isa sa mga sinasabi ko that's hereditary, no? And some medullary thyroid cancer can have, as I said, family history of the disease, and the culprit will be a faulty gene or genetic mutation. Yun yung the thing that we will blame, but we really cannot change kasi we're born within the family who has a lineage for that particular type of cancer.
And doctor,
then the last one, yes, Nicole.
Oh, go ahead. Sorry, doctor.
Okay, the last one is the one that I don't want to see because it's called an anaplastic thyroid cancer, because this one is the most aggressive form of thyroid cancer. It is the most difficult or the hardest type to treat, no? So it occurs in people who are older than 60 years old, so medyo an elderly, no? It can cause severe signs and symptoms, and it could produce neck swelling, or it also worsens very quickly. In a few weeks or months, you will see that the neck is really enlarging, nag-engorge siya because of the tumor is really getting bigger. And the patient has difficulty of breathing and sometimes difficulty of swallowing. So it can grow very quickly. It can spread also rapidly into the surrounding tissue and other parts of the body. This rare type of cancer accounts for, within the lung, it's very rare. It's just 2% of the thyroid cancer diagnosis. It's not as common as your well-differentiated thyroid cancers, your papillary and your follicular.
Do you know what causes the cancer that you don't want to see?
I think it's still genetic, no?
Genetic, okay.
As I said earlier, talagang experts really don't know what's really the main culprit. One has that, but I think genetic mutation still plays a role in that.
Yes. And doctor, when we say genetic and genetic mutation, just to clear it up with people, it could be like it could skip a generation. Like it's not necessarily that one of your parents or both have it. It could be, or maybe a cousin has it. I mean, it's something just in your lineage, in all the genes that you have so far in your body that you've inherited, and it somehow cancer is expressed by one of those genes.
Yes, especially for medullary. If one of a family member has it, then the direct descendant, like the kids, the children, should be tested for it. But it doesn't mean they would really develop 100%. As you said, it could skip a generation or two. But then it's better to have it checked or screened.
Yes, thank you, doctor. Okay, so when it comes to the cancers that you just mentioned, I mean, how do you diagnose these cancers? Are the procedures all the same, or maybe you can just give us a sort of an overview, whether it's lab or ultrasound,
Okay.
and how can they be detected early in that sense? Okay,
Okay.
because you did mention that somebody should be screened. Do you want to talk about screening first, or how the
Okay. So, okay, about screening, should we screen everybody, as in all people? If we have thyroid cancer,
Yes.
everybody who goes in the clinic, should we do that? Actually, no. If you're healthy, if you don't have a family history of cancer, if you did not undergo any radiation procedure of the head or the neck, or no history of being exposed to like nuclear, like the one in Japan before, Fukushima, yeah, mga nuclear explosion or nuclear, anything like that. So you're not naman at risk, no? Those at risk will be the one with a family history of either a papillary or medullary type of cancer. Then those are the ones that we would need to screen or to check. Most people, they go to the clinic and they will complain already that they palpated a node, no, or a buccal or a mass in the anterior neck, and that's who we check. And how do we check it? We check it by doing some tests, no. As you mentioned earlier, an ultrasound is a good modality to check for the thyroid gland. It will determine the number of nodules if there are more than one, no, in the neck. It will also determine the size and the characteristic of the thyroid nodule or the thyroid mass. Another test will be a blood test. Your TSH, for sure you've heard about thyroid stimulating hormone or TSH, and the free thyroid hormone, your FT4 and FT3. We usually check these parameters. This is a blood test again to check the hormones and gauge whether the thyroid is functioning properly. Because there are patients who have hyperthyroidism and some have hypothyroidism. We have to make sure that these patients don't have those. And if they have, we treat them accordingly. Then once we get the blood test and we have an ultrasound and we determine that there's really a mass there, depending on the size or the characteristic of the mass, the doctor could request a biopsy. A biopsy is the fine needle aspiration biopsy, wherein the doctor would put a needle into the mass and then would get a few cells of the thyroid mass, not the thyroid gland, okay, the nodule or the mass, yung buccal, and test it if it has cancer cells, no? Sometimes there are lymph nodes also. We can also get a sample of an enlarged lymph node and check under the microscope, see its characteristics of the cells if it is cancerous. So those are the tests that you do to determine if or diagnose if one has cancer. The biopsy would let us know that.
Thank you, Dr. That is so thorough. Actually, since you started talking, I was like, wow, what a great voice with authority and also understanding of the whole topic. But that's so great how you said it, because
Thank you.
some people will have will let's say, okay, if you don't, so basically I'm just repeating what you said. If you don't have a history, you don't have to be screened. Okay.
Yes, you don't have to be scared, but you have to go to the doctor
and you have to be screened. And I imagine there are a lot of people who you see who are scared when they first come to you, and in fact, like sometimes it scares me too, but because I tend to bring a lot of people, to the doctor. That's I don't know. That's why I do this show, because it's very just like interesting to me. And I feel that I hope this is a platform that can. I know it's a platform that reaches a lot of people, so I hope they're more aware. And then, so for like, let's say somebody has been screened, regularly, and they say, okay, you just an endocrinologist like yourself will say, okay, just monitor, because there are nodes in the throat or in the thyroid gland, and if they don't get big, or if they don't, the medication is not even needed, but monitor, and also with the TSH, the T3, am I saying
T4, yeah.
Yeah. Okay. So, and then for those blood tests, you don't need to fast for the
no fasting needed for those blood tests. Correct, Nicole.
So once you have all those things together, and then you evaluate the patient, and you say, okay, let's just make sure what you do is a needle, a fine needle
aspiration biopsy. Correct.
you just get part, as you said, of the mass, not the thyroid gland. You get
Yes,
part of the mass or the masses there, and then that will undergo testing.
correct.
Okay. So I just wanted to make that clear, because if someone's in that stage, if it comes out that it's negative for cancer cells, I guess we're going into like um a bit of treatment already, but there's a mass there. Do you? Okay, we'll deal with that later. But I just want it because it's already here. Like, do you recommend taking that out?
Okay, if the result is benign, because if you do the biopsy, the pathologist will study the cells, no, under the microscope. They will see it, they will check it. Okay, there will be categories when you do the biopsy. It could either be non-diagnostic. So some patients, they have that. Wala masyadong makuwang cells. So we cannot say, is it cancer? Is it benign? Is it what is it? We don't know because we did not get enough cells. That could happen. That's the category 1, no? The other one is benign. When it's benign, you just observe. Sometimes it's really difficult.
Yes.
It's really difficult to biopsy a thyroid nodule or a thyroid. Lalo na kung maliliit, no? Sometimes you really don't get cells. Mailap yung cells even when you poke a lot. It really doesn't want to go to the needle. So it's non-diagnostic.
Even the cells are afraid of the needle.
Maybe. Most are. And that includes the cells, I think, Nicole. So the benign naman, if it's benign, okay, nothing to do. It's benign. We don't tell the patient you have to go to undergo surgery. It has to be removed, but it's benign, so that's okay. We just observe. We just monitor. We just make sure it doesn't grow bigger. If it does grow bigger, then we need to do a biopsy again. Maybe after a few years na yon. It's not like a month or a year. Most of the time, it's a few years after. I told you earlier that thyroid masses tend to grow slowly, especially those benign. Sometimes they don't grow bigger at all, no? They just stay at the size they are in when you first diagnose it or you first see it. The other category will be those that in between. It's not benign, but it's not cancer. It's atypical. So it's in between. That's Bethesda 3 and Bethesda 4. That's what we call it. It's in between. So we still don't know if we should be worried about it or not worried about it. What we do is sometimes we ask the patient to redo the biopsy if it's Bethesda 3. If the classification is 3 in the biopsy. If it's 4, we could actually advise a patient we could do a lobectomy. Lobectomy is removing one part of the thyroid. I will show you again the gland as I showed you earlier. If there, for example, there's a nodule here. Wait, I have here with a nodule there. For example, this is a thyroid gland. If you would see this one, this is a bigger chunk, no, of thyroid. It's a nodule. So if you biopsy that, if you poke into that, no, so halimbawa, ito yung needles, halimbawa lang, you biopsy that, and you get the cells, and the pathologist will tell you, "Oy, this is atypia." That means it's a little bit irregular, but I wouldn't say it's cancer. No. So what you do is you would observe, go back to it. You could do another biopsy in like 3 months or 6 months time. Okay. If it's a stage Bethesda 4 is follicular neoplasm, you could actually remove this one.
Okay.
The portion where the nodule is, this is a nodule. No? You can actually remove this one, or even the isthmus, the one that connects the left and the right, or the right and the left node. No, and then you maintain this one. So the patient will still have a thyroid gland that's working. You don't remove everything. No.
Okay.
So that's for stage 3 and stage 4. You can do if you want to be more aggressive. The doctor is more aggressive. You can remove just to make sure that this is not cancer. Okay. Then there's Bethesda 5 and 6. For Filipinos, studies will tell us that Filipinos are more prone to have thyroid cancer.
Okay.
And more prone for the thyroid cancer to recur and to spread.
Okay.
We're so malas, no? They compare it to other race, no, to other nationalities, no, and Filipinos are like that. Together with the Japanese, no, our thyroid cancer tend to be more aggressive and tend to metastasize more than the other nationalities or the other race, no. So if one is diagnosed during a biopsy to have a 5 that is suspicious for cancer, or malignant, as in it's really malignant. They poked, they got cells, and the pathologist will say that's cancer. You have to take out all. The left, this is my left, so the left,
yes,
the middle, and the right.
Okay.
If your ultrasound will show lymph nodes that are also affected because the cancer here could have spread already to the lymph nodes.
Yeah.
Then you take out also the lymph nodes. You do neck dissection, no? You remove the lymph nodes. That's also positive, or that's also enlarged. So that's how you address, or that's a treatment for a thyroid cancer. You remove the thyroid gland. All of it, if it's suspicious for malignancy and if it is malignant.
So, doctor, okay, so I guess we've gone through talking about the stages that you would call it. And then, like, some are, I guess, classified as benign, no? But you check it, but you classify it already. They're benign, so okay, you don't have to do anything. Just have a quick question. If let's say there's some kind of, a bit of a lump there, because maybe I should get to that later. But okay, I'm here already, so let's go to it. A bit of a lump there, it's benign, and then it doesn't grow. But some people, they don't want it around their neck, and it doesn't seem to recede. Do they get like electives? Do you know of anyone who's got an elective surgery just to remove that kind of lumpy mass?
Actually, we do not recommend removing the mass if it's benign, if it's not causing any form of discomfort. The reason why a benign thyroid mass will be removed is if it's too big. It's hard to swallow. When you drink water, it's like nasa samid, no? Or it's hard to eat because the lump is really big, but it's still benign, no? It's not cancer. The other one could be you have difficulty of breathing. The other one could be because it's so big, even it's benign, sometimes may hoarseness of voice. Sometimes that happens also, but mostly for the malignant ones. Pero if you develop symptoms that's caused by the benign lesion, that's when we advise the patient to have it removed. But if it's small and it's not growing, we do not advise surgery. We could monitor depending on the size, we could monitor annually or every 2 years, even some, if really small, every 5 years.
Thank you, doctor.
If it doesn't cause harm, it will not cause harm. It doesn't look cancer. Let it stay there. That's okay.
There are a lot of people, I imagine, who would be like, I just want it out, or even because it's a part of the face and the neck, even just for not really vanity, but it's more like they don't feel like themselves if it's there. Well, if it's not big and it's not that, it's palpable because you can feel it when you keep touching it, but it's not palpable. Then, people don't go around saying, hey man, your neck looks fatter today. Then don't.
Sometimes really just have a fat neck. There's a mass or there's a nodule, like a 1 cm. 1 centimeter is just like this small. It's just like the size of your fingertip. Ito with ng fingertip mo. This 1 cm, you can hardly touch it. But then they say, my neck is too big, doctora. I want to have it removed. No, your neck is big. You exercise, make it smaller. You eat less for it to be smaller.
Yeah. I have a big neck right now, and it is getting smaller. So is my double chin. I've always had. Even
maybe
when
they need more of the aesthetic, not the surgeon for the thyroid.
Okay. And so, doctor, okay, you did mention a lot of things already about, we've delved into diagnosis, some treatment, but when you spoke earlier, you said, okay, if the nodules are, how would you know that it's spread, basically? Like if it's whether it's the less, whether it's the papillary or the friendlier ones that you don't have to freak out about, or the more serious ones, how would you know that it's spread already? Would you see it in the lymph nodes yourself? Are there other tests for that? Do the blood tests show that? Are there cancer tumor markers that you can really rely on?
Okay. When we check a patient, so let's start again. There's a nodule, and then you had ultrasound, and you see in the ultrasound there's really a nodule there. You do biopsy, and then when you do biopsy, it's cancer. You take it out. Then how would we know it is spread? If the ultrasound would identify lymph nodes, so when you do surgery, take out the lymph nodes also. But after surgery, how would one know if it's not spread to the other parts of the body, like the bones or the lungs or the brain? There's the thing we call whole body scan. We do the whole body scan after surgery, 1 month after surgery. Once the wound is healed, hindi na masakit, the patient is more kampante na, hindi na siya masyadong scared, naoperahan na siya. 1 month after, if it's a papillary thyroid cancer or a follicular thyroid cancer, those would warrant further treatment. No, it's called radioactive iodine therapy. But before I go there, after the surgery, 1 month after, we do a whole body scan. Okay. So when we do a whole body scan, it will scan from head, no, from head to foot, no, your entire body. Sometimes we do this before radioactive iodine therapy. There's a therapy after surgery or after. Most of the time we do it after. Okay. So what the steps will be: surgery, then let the patient rest. And then after a month, we do radioactive iodine therapy. The action of that procedure is to kill whatever remnant cells or tissues would be in the neck. So when it gets killed, the possibility of metastasis will be lower, or the spread will be lower. And then a few days after you've taken the radioactive iodine therapy, it's just a pill. No, it's just a pill that you take. No, you'll be in the hospital. It's an admission. You'll be admitted like 2 to 3 days after you take the pill. And then before you get discharged, you'll have a whole body scan. The whole body scan will determine if there's spread in your body. So you would know already. Most of the time, if it's papillary and follicular, we don't really see after the surgery and after the whole body scan, our radioiodine therapy and then whole body scan. We don't really see. We just see like a focus or increased absorption of the radioactive material that has been swallowed in the neck, because that's where the place of the thyroid mass or the thyroid cancer is, and it ablates or kills whatever remaining cancer cells there are there. So, and then if there are kalat or metastases in other parts of the body, that same procedure, the whole body scan, would light up in those parts like the bone or the lung or any other part of the body that's a possible metastatic site for the cancer.
Thank you, doctor. So, okay, just to recap, when you do the and I have questions. When you do the radioactive therapy, because I've known patients who have gone, like, they do it for a few days in the hospital, and they're this is not yet the whole body scan. They go for a few days in the hospital, and they're confined. They have to have their own room. They're confined, and then they do the radioactive therapy. So it's not really a very scary thing. Of course, it's scary to have it, but the procedure is not very, very scary. So I guess your first order of business is, if you find cancer, you address it, you remove it, and surgery. Then perhaps you decide we'll do the radioactive thing to kill whatever is there. And after the patient has recovered from the surgery and there's no infections and all that, and then you can also do the whole body scan. Is that a new technology now that you offer?
Not really. It's been there since I was in training. It's been there already.
That was only a few years ago, even though you're...
It's actually really a procedure that you do after you do a radioactive iodine therapy. No, so you would really see if there's metastases, if you need to go further, if you need to be more aggressive with the patient, and also for the staging of the cancer. Because if there's metastases in any part of the body, then it will call for a higher staging. No, so the staging for cancer is 1 to 4.
Yes.
Sorry, I'm going back to staging. I think we missed a little on the staging after the surgery, no? So the staging is 1 to 4. You're lucky if you're diagnosed with cancer and you're less than 55 years old, because there are only 2 staging for papillary and follicular cancer. If you're less than 55, it's either a stage 1, wherein the cancer is confined here, and stage 2, if it has spread to the distant parts of the body, okay? But if you're older, you're age 55 and older, then the staging will be from 1 to 4. So the higher the stage, the more the metastasis is, or the more the spread of the cancer is. It could be in the nose, or it could be in any other part of the body that's not in the neck.
It could be in the ingrown. Just kidding. Umabot na sa ingrown. Hindi pala ingrown yun. Okay. So, doctor, when you do the radioactive pill, just to describe it to patients, so when the patient gets to the hospital, they drink this radioactive pill.
Correct.
And after a few, I guess you make them wait. Please jump in anytime, correct me if I'm wrong. They just have to wait. So it's a pill that they drink, okay?
Correct.
Then they just have to, it's not an injection. Then they just
It's
have to
not.
few hours, and so that it circulates around the body, the
Correct.
radioactive material. And then you do the scan. What machine do you use to do the scan, doctor?
It's a whole, but it's a machine. In usually the place where you have it done is in nuclear medicine.
Your
It's a
medicine.
whole body scan, no? So it's a procedure wherein you're lying down and your body gets scanned, no? The radioactive iodine that you took a few days before would go to the different parts of the body wherein there is thyroid tissue, no, or thyroid cells. So if the thyroid cell is only here, then the only one that will light up will be here. But if there are thyroid tissues because of metastasis to other parts of the body, that would also light up. When you do the radioactive iodine therapy, there are some preparations that one must do. You should eat low iodine containing food, low iodine diet, no? So wag ka muna kakain ng mga seafoods, mga seaweeds, mga sushi, sashimi, crabs.
May mga salt na may salt.
Iodized salt. You should also avoid iodized salt. And then when you've taken already the pill, you have to drink a lot of water. So the radioactive iodine pill will also be flushed out in your system. So kinakailangan din kumain ng marami. And there are other parts na of the body na pupunta din yung radioactive iodine, like your salivary gland. Sometimes the patient will say, aray, ang sakit dito, because the salivary gland, yung saliva, it tends not to come out of the gland when there's like absorption of the radioactive material, no? So what happens is that parang masakit. So we ask the patient to take something, mga sour candies or sour food, no? So they will salivate para lumabas yung saliva. It will help for the saliva to come out para hindi masakit yung salivary gland yan. Here.
Okay. Thank you, doctor, for describing that. It's also, I believe, important for them to know na, what is this procedure about? And then the procedure actually doesn't take that long, right? But as you said, if there are, and I'm so glad you mentioned this, you're directing it towards the cells of the it's not just to say that, you have these places lit up. Parang when you see it in the scan, it's lighting up here, it's lighting up there. Of course, you expect it to sort of light up in the where the thyroid gland is, but there's something very interesting to me that you said where parts it's directed towards the parts of the thyroid gland that may have or the mass that may have spread to the other parts of the body. Correct. Because I guess, thyroid and iodine really do, they really do connect. I'm just guessing, so please
it's
correct me if I'm wrong.
Iodine is the food for the thyroid gland.
Yes. And then so like if you find it in some other part of your body, because it's that part that's the one that tells you that it's spread there. It's not just like, how do I know if everything is lighting up for any reason?
That's parts of the body that would light up also, like the salivary gland, as I mentioned earlier. It could also light up in your stomach and the urinary bladder. That's okay. The doctor will not call that as any problem or any disease organ. It's not. It's the one that lights up in a different part, like, for example, your brain or the bones or the lungs. Those are the common ones, actually.
Yes. Thank you, doctor. And not the what do you call this, ingrown?
Not the ingrown. One more thing, Nicole. When you get admitted pala for RAI, you have to remember you are isolated. Because the radioactive iodine, when you take it, you don't want other people to be exposed to you because you're kind of radioactive. This radioactive iodine, that if you are exposed to other people, the effect on other people could be, they could be hypothyroid, especially the pregnant ones or the kids. No, so we advise them not to go near, even if they've been cleared to be discharged. Ganyan. So they have to be a few meters away from the kids and pregnant women, no? And also from other people, kahit na ibang tao, halimbawa, you'll be going home, you just had your radioactive iodine therapy, and somebody will be driving for you, no? So you have to be seated,
in the back.
Halimbawa, yung driver, dito ka sa kabila, sa opposite side,
Doon ka na lang
no?
sa
Like
trunk.
a meter away, ganyan.
Doon ka na lang sa trunk, hindi. I'm
Sa trunk na lang.
doctor, pero sometimes we have to make light of situations that stress us out.
Yes. Correct. I agree with that.
Thank you for reminding us about that, doctor, because of course our first instinct is to, especially if you come from a loving family or the home that you're in, everybody will go near you, you'll want to talk to
Correct. Baka i-hug ka, ganyan, or i-kiss ka. No kissing muna. You tell the husband, no kissing. Sleep in a separate room muna for a few days, just to make sure also. Even if you've been cleared already, meron pa rin yan may tira-tira pa rin yan, just to be sure.
And you have to flush it out of your body.
Correct.
As you said. Okay, doctor, once the thyroid is removed, can the cancer still come back? I mean, somehow a cancer associated with the first cancer of the thyroid that you had, can it still come back?
Actually, thyroid cancer can recur. Pwede siyang bumalik, no? Magkaroon na ng recurrence, no? Even after treatment, no? Because the thyroid cancer can grow slowly. Di ba sabi sa inyo, matagal siyang lumaki. It could take up to a few years, even up to 20 years before it comes back. The recurrence happens around maybe 30% of the thyroid cases. For papillary and follicular yan, ha? Okay. Not for the anaplastic one. Because the anaplastic one is really aggressive, no? And the patient, the prognosis of the patient is lower, way lower than the well-differentiated.
So doctor, even if the gland is out, it can still come back?
Yes, it can still come back. So that's why you have to make sure you go back to your doctor. You monitor for certain proteins in the body, like your thyroglobulin and antithyroglobulin, because your thyroglobulin is a protein in the body that once your thyroid gland, the entire thyroid gland is removed, it should be really low. It should be actually very low, lower than the normal level, because you don't have a thyroid gland anymore. And your doctor will monitor that. And then if it goes up, then maybe you would need further tests to check if there really is recurrence. You would need actually neck ultrasound again, so the whole neck, just to make sure that walang natira, there's no tumor recurrence, you don't see other bukol or lymph nodes, because that could be seen with neck ultrasound. Then the other one that we do to really check is we redo, maybe after 6 months, if you think after 6 months there's a recurrence, or after a year or a few years after there's a recurrence, we also redo the whole body scan. The whole body scan is done after the radioactive iodine. Not the radioactive iodine now. What we do is the test, the whole body scan. Again, scans from neck to foot, no? And then it will determine if there's kalat or metastasis, or the cancer has spread to any other part of your body.
And if that occurs, doctor, do you then treat with other things, like, let's say, chemotherapy or pill therapy or other? Okay,
chemotherapy is actually reserved for those really thyroid cancer does not respond to the first line therapy, which is surgery. If there's a bukol again there, then we do again another surgery. If you've had RAI, it's okay to do a second, a third, or even a fourth radioactive iodine therapy. But sometimes the metastasis, or the one that has spread, or the one that recurred, is not what you call radioiodine avid. It means even if you give radioactive iodine, it does not absorb it. You don't see it. Even if you do the thyroid, the whole body scan, you don't see anything. You think, ay, walang cancer, because you don't see anything. But you have to be more aggressive if your other parameters, like your thyroglobulin, is elevated, and you see a nodule or a lymph node or any other disease area in the neck ultrasound. It means something's still there, even if the whole body scan will say otherwise, no? So you have to be more aggressive. Sometimes you do other tests, like a CT scan, an MRI, or even a PET scan, no? To determine if there really is spread of the cancer. Going back to your question about chemotherapy, it's rarely used for thyroid cancer. It can be used for anaplastic, the more aggressive one. But for the well-differentiated thyroid cancer, the treatment really is surgery and radioactive iodine therapy. Yes, only for those really challenging, talagang ayaw umubra yung first two treatments mo. That's when we use the other kinds of treatment. There's what we call tyrosine kinase inhibitors. There's brachytherapy, radiation therapy also for dun sa makukulit talaga na ayaw matanggal with the first line treatment, no? Let us not forget pala the medication that we give after we remove the thyroid glands and after the radioactive iodine. The thyroid hormone. Let's not forget the thyroid hormone. We call it levothyroxine. Most of your audience.
What is it called, doctor?
Levothyroxine is a thyroid hormone that replaces. It has two actions. Number one, it will replace the function of the thyroid gland. So you need levothyroxine. It will be your replacement for the function. So it's a thyroid hormone. The other one is we want to suppress or make sure that your thyroid stimulating hormone, your TSH, will be low. As in 0.1, sometimes 0.1 to 0.5, because the normal is like 0.4 up to 2 to 3, no, the TSH. But if you've been diagnosed with thyroid cancer, don't worry if your TSH level, when you go back to the doctor and the doctor has given you levothyroxine, the thyroid hormone, is like 0.1 or 0.2 or 0.5, or even sometimes it's less than 0.1. Your doctor really would like your TSH to be really low to suppress, not suppress whatever those cells attempting to come out and multiply, no? So parang hindi siya kumalat at dumami, Nicole.
Thank you, doctor, for saying that. That's very informative because, of course, after some might panic, oh, now it's too low, what's happening? But it's done on purpose.
It's done on purpose. Correct.
Yeah, I knew someone who didn't want to take the medicine afterwards, the maintenance. And I said, well, then you're just going to continue having these,
Yes, they'll be hypothyroid. They don't have thyroid medication and their thyroid has been taken out. They feel sluggish, they feel sleepy, they look manas, their heartbeat will be slow.
Exactly, that's exactly. And then I was like, oh, okay, well, it's up to you, but the doctors have told you already what to do, and you just have to accept that it's maintenance. At least you were saved. You were covered. Okay. So, doctor, when it comes to if you just leave it untreated, because a lot of people will be like, hayaan ko na lang kasi sabi nila, I've heard this a lot. It's benign and I don't want to bother checking, or I don't want something to be removed because it might affect my the voice or the hormones, or what happens then? I mean, what's the best and worst case scenario?
If you have thyroid cancer and it's untreated, it depends actually. If it's micro, meaning it's really small, less than 1 centimeter, sometimes it's okay not to remove. Sometimes, it's really small. You just have to observe the nodule, and if it doesn't grow, it's okay that it's still there. No, that's okay. But most of the time, as I said, Filipinos, we are more prone for the thyroid cancer to be more aggressive, to be more spreading, or metastatic, or recurrent. That's why mas aggressive tayo. So I do not advise for people who has been diagnosed with thyroid cancer not to have their thyroid gland removed, or even a portion, kahit portion of the thyroid gland, if the thyroid nodule or the mass is really just very focused or focal lang, nasa unilateral, maliit lang, then you can just remove a part of the thyroid gland, and that's okay. But if it's, as I said earlier, if it's stage, the Bethesda classification, when you do the biopsy, it's 6 or a 5, then you have to take out the entire gland, because it could spread, it could go to the other parts of the body, and we really do not like that you have more cancers in some other parts of your body rather than just the thyroid. And I said, if you treat it properly, the prognosis is really good for the common thyroid cancer. So why would we not treat it when we know if we treat it, if like you have 5 years and you will say, doctor, in 5 years, will I still be alive? I'm going to say, yeah, 100% you're going to be alive. Just follow your doctor. But if you don't follow your doctor, the percentage will really go down.
Yes, thank you, doctor. And also for those who are, they have something, they're not sure, and they're getting up to the point where they need a biopsy, or, for all of that. Can you tell us what happens if you delay it? Because some people, I'm too busy, or there's a lot of things that go on, and they don't, and it's, I mean, if you delay screening and you know you have something, or if you delay just getting the tests, like, should we deal with it immediately? You did say that for some it's very slow, the growth, but
Yes.
how about the
But
other?
for others, even if konti lang yung numbers, the growth is more abrupt or faster, no? Some papillary kind of cancer, yung iba niyan kasi mas aggressive, no? Most are not, but some can be aggressive. And then they tend to get bigger, faster, and then they tend to spread more rapidly. If the thyroid nodule or thyroid mass becomes bigger, when you do the surgery, hindi natin pwedeng hindi tanggalin lahat ng thyroid gland. Then if it has spread to the lymph node, you would also remove the lymph node. So you could imagine the hiwa or the surgeon that could just be like this, ganito lang, kaliit, ganito. It could spread like this, pag malaki. Or it could even go up to here. Your hiwa is here, you have hiwa here, you have hiwa here, because you neglected the thyroid cancer, no? So do not neglect it, because the treatment will be harder. It will be harder to treat. And the metastasis, baka hindi natin mahabol if there would be any spread already, if we do not treat it immediately.
Thank you, doctor. So, like, don't delay, don't take it for granted if you have issues already. And also, doctor, can I ask you what lifestyle changes, even just very quickly, are there any lifestyle changes that you can make that will help you avoid? I mean, unless it's genetic, or does it work both ways that will help you avoid?
Okay. Yes. Always, lifestyle will be proper eating, your diet, no? Eat healthy. Do not forget your vegetables. Do not forget your fruits. You have to have physical activity as well. Exercise. Do not be sedentary. Hindi pwedeng puro tayo watching the TV or on the gadgets, no? So you have to move, no?
I'm smiling because I'm guilty.
Kasi obesity also is like you're cancer prone if you're like big, if you're obese, no? So we have to make sure we're, we have a fit, our body is fit, no? We eat properly, and then make sure you sleep early. How many of hours of sleep do you get in a day or at night, Nicole? So sleeping 6 hours or more would be good, no? And also stress. Remove unnecessary stress in your life, no?
Remove unnecessary stress. Okay, that is probably one of the most difficult things to deal with. I'm sure you also like, if you work as a team and you have a patient and it's individualized. I know you individualize your treatment.
Correct.
You can recommend therapists or counselors or psychiatrists even to help with, to help the patient go through all of these things. And maybe what's required is a whole new view just to.
If you can find a support group, Nicole, diba? If our patients, if our people with cancer can find support group, you can ask your doctor if they know of any support group for their particular kind of illness. Then that will be good. Because talking to somebody about your illness, a person who experienced the same, went through the same endeavor or same illness, then that would really help a lot. More than not just the family. Of course, family support is very important, but sharing or having a support team would also do any cancer patient good.
And perhaps family members who really get affected can also have their own support groups or ways of supporting themselves for around the patient. And then, doctor. By the way, doctor, can I get your number after the show? See, I'm putting in the spot. I really, really, really would like to get your number. And I think I may be able to send people your way.
All right, that will not be a problem.
That will not be a problem. Okay. So, so we do have a question here. I mean, do you have any advice for those who have thyroid cancer or maybe think they do? Oh, the symptoms pala. Maybe you can include the symptoms and that advice. If you're feeling this, if you're feeling that, then maybe you do have, also just any advice for those who are going through it, or maybe their family members, anything you'd like to say.
Okay. If you think you have the signs and symptoms of a thyroid cancer, so the sign or a symptom could be just a lump in the neck, have it evaluated or checked by your family doctor, or even go to an endocrinologist or an internist or the family doctor that you have. They will be able to know how to deal with it. So the symptom will be a lump that you could feel. Actually, when you do like this, you could already touch your thyroid gland. And if you, palpate or touch it a little more deeper, deeper, then you could really, when you swallow, you would feel that your thyroid gland is there. No, sometimes the symptom could be a growth in the neck or in the thyroid gland. Sometimes it could be a change in the voice, medyo nagiging hoarse of voice, nagiging difficulty swallowing, pag medyo malaki na, even your swollen lymph nodes, or pain. Sometimes pain then in the neck and the throat. No? Those are the symptoms. So please see your doctor and follow the advice of your doctor. Hindi po pwedeng pagpaliban or next month na or next year
Bigyan
na.
ko lang ng Vicks, ganun. Tapos baka mawala.
baka mawala sa Vicks, no?
Hindi naman yung sore throat, iba yun sa sore throat.
Ay, ba yung sa sore throat? Hindi
Brain
yun.
Vicks, pero
Sometimes
iba
kasi
na
if
yun
really
sa sore
big, no?
throat.
Sometimes it compresses in the other parts of the neck. It tends to be really painful. Sometimes that happens, no? And then make sure you have to of course, everybody has to deal with it. And how do we deal with it? So sometimes it's really hard to cope, no, with cancer. The cancer, its treatment. Sometimes with physical changes, you see the scar, you get so depressed. You have a keloid there, and it's big. Sometimes it could be this big, nga, diba? So you have to have people with you who will help you boost your self-esteem, and other people you could really talk to. And as we said earlier, healthy diet, physical exercise, if you could already do it, no, physical activity, don't hesitate, no. It will really help in addressing the cancer and making sure that you will not have recurrence.
Thank you so much, Doctor. Thank you for sharing your time, effort, and intelligence on this show. That was such please come back anytime. And if I can have your number, I don't know if you want me to get it through Micaela or if you want to.
Yeah, Micaela, can just, Micaela, she texted me.
Micaela, I have
That's from her, it's okay. Not a problem.
Thank you so much, Doctor. That's all the time we have for today, folks. But tune in again next week to Healthline with Makati Med, and you'll see doctors as wonderful as Dr. 𝗠𝗸𝗁 here. Thank you so much, everybody. Take care, stay healthy, and have an uplifting, healthier and uplifting lifestyle. Thanks, Doctor. Okay.
You're welcome, Nicole. Take care.
Take care.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of Healthline.
The views and comments of the hosts and guests are not necessarily those of the